have 5 great people who are participating in the panel. They're each going to open with a few remarks, and we've given them a few questions to help shape those remarks. So we asked them, what are the big issues facing the country or your specific region or province that need addressing? What's your vision for the role that IT and digital health can play to address these issues? What's the most interesting thing that you're working on? And how do we need to work together to make progress, or do we? So that's sort of the framing of our discussion. Each of them is going to start with opening remarks, and then we're going to open it up both to a conversation amongst our panelists and also with the room. I'll just remind you that there are mics in the room should you wish to participate in that part of the conversation. If I read each of their bios to you, there would be absolutely no time for conversation. So I'm going to do the very quick version that you also see on your screen. We're going to start with Bill Clifford from Northern Health, Tim Fitzpatrick from Health PEI over there, Mary-Lyn Fyfe from Island Health, Glen Geiger from the Ottawa Hospital, just there, and Jeremy Theal from North York. So Bill, over to you.
So I think from the most important thing from my point of view for what's facing us today in healthcare in the country is a more effective way to enact primary care. It's unequivocal that primary care improves health care quality at a lower cost. Barbara Starfield's work in the 90s demonstrated that very conclusively. Also, primary care occurs in very much larger numbers of encounters in any single day than hospital care. In fact, hospital care is only about 1%, and primary care does offer us an upstream way of dealing with the problems that we have with hospital visits and load and costs. We have a model in the country for deploying primary care. It's called the Patient-Centered Medical Home from the College of Family Physicians Canada, but it's matching from other jurisdictions, including the US. And it has, the animations aren't working. It has a number of different pillars. And the pillars from continuity of care, continuous care with the family physician as the keystone, the cornerstone of the medical home, but with timely access, team-based care, and of course, because this is an IT conference, I'll circle electronic records and health information. Those health information, or the IMIT supports, are needed at the point of care for workflow and documentation, clinical decision support, also needed for quality improvement and safety, and quality that extends to people that are not just in the room, but in the practice as a whole, representing a gap in care, and also to inform our population health and information. Also, professional self-regulation is becoming embroiled in all of this. Physician remuneration using the technology of an EMR to determine complexity to base payment. And of course, we really need a learning health system to support quality improvement research as health system strategy. You really do have to press this. On the team-based care front, we're trying to move as a country, I believe, from multidisciplinary team-based care to interdisciplinary team-based care and ultimately to interdependence. But for interdisciplinary care, we do need effective care planning, electronic care plans if we're going to be using electronic medical records that can do things like look at goals and preferences and resources and barriers to care. And in order to do that, it's going to be necessary to have data standards, common data set for clinical structured documentation, as Dr. Harris pointed out this morning, and the interoperability system to be able to share that kind of information. This is a representation of the learning healthcare system, where all of these levels are represented right at the point of care, including personal health records, and the uploads of things like your Fitbit activity into there for true home health monitoring across the full spectrum. To the practice level, to the population level, and then to the broader public for evidence-based guidelines and what's a useful contribution for everyone. Our barriers at the moment, though, are legion. We have electronic medical record adoption all over the place, but we have real problems with meaningful use of those electronic medical records. Where in this Infoway emerging benefits, I thought that we're at the emerging level, only 3 to 7% of people using EMRs are able to or are effectively doing chronic disease management with those records. We also, in the spirit of quality, reflection, gap analysis, and the stuff above the patient level, need dashboards, cockpits, and scorecards. like these from primary care data that can be shared globally, and this is the most exciting thing that I think I've been working on, or the most interesting thing about using safe distributed technologies, safe from the patient privacy point of view and the provider privacy point of view, to share primary care data so that we can do things like look from primary care data how we're doing with attachment to primary care, as this represents for our Prince George Division work, how that compares with the rest of Canada, which actually, if you look at the yellow for 2013 data from StatsCan, very, very similar. Also showing that horrible waste, which is figurative and literal, in the 50 to 60-year-old group, moving up, and resulting in increasing disease prevalence. And again, this is from primary care data. This is real-time data. We have it just days old to show that the prevalence is rising. That we have, though, because we have this distributed approach, which I'm hoping in my dreams that we would have across the country, we're able to support physicians or primary care homes to compare their performance, like the green triangles there, to their own performance for things like fecal or colorectal screening, which is actually quite easy because we have the interoperability solved for labs and those kinds of discrete things with our common distribution systems. And we can look at the distribution of the results like this, where we can actually go to the right-hand side of this and find out who's doing things well and what rules are they breaking in order to do things well. And in the spirit of Northern way of caring, we will not send Luigi and the cement truck to the left-hand side of the graph. But as Dr. Harris was talking about the discrete entry, things like tobacco use, weight, actual measuring the weight, and then being able to translate that into tobacco use prevalence, obesity and overweight prevalence, is immensely useful to track about outcomes about our interventions in primary care. So in short, the critical success factors from my point of view for all of this and working together is that on the business side, we need a commitment to quality and to safety. As again, Dr. Harris said, it's almost like he stole my slides or I stole his. Good data quality that feeds into all of that. Interoperability so we can exchange it, including to the personal health record. Having clinical decision support at the point of care, but that contextualize the evidence and is predictive. All of this will require from the business side coaching and peer mentoring in order to be able to really actually make it work so that we can have effective reflection, effective quality improvement, especially in things like small groups, like the McMaster practice-based small group learning program, and that overarching all of this, that citizens and providers will feel like their data is safe. Thanks.
Thank you very much. So it turns out that the slide clicker is like the talking stick. And it now passes, there we go, to Tim.
I'll stand as well, thank you. I'll have to disagree with Bill a little bit. I come from acute care only, and in PEI we don't have a primary care EMR, so of course it can't be that important, right? I'm an anesthesiologist, and I got interested in this whole aspect, and I'm not nearly as smart as these guys. I didn't even bring my socks today. I got involved in it because of bad patient outcomes that I saw every day that could be changed. And I got frustrated with mistakes that were made in the paper-based system, and I was against all this transformation. I was not an IT guy. I'm old, I'm 50 now. But when they forced me to do it, and I started realizing I could find things out ahead of time and plan for my patient's care, I got interested. And then when they showed me CPOE and the order sets, I was hooked. And that's what got me involved in this whole process. We've taken PEI, the hospital-based record, to a fully implemented provincial system. All the information is there. The PACS is outside the system, but it's fully viewable. Reports are on the system. We have CPOE all across the province and all the hospitals now, but we have no primary care electronic medical record, and we're trying to move on that. So looking at the questions in the context of this meeting today, Atlantic Canada isn't getting together yet. And there's no really good reason. We all voted Liberal this time. We need to get together. We share a lot of things, including our patients. Theal, the Halifax is the tertiary care center, and so we often send our patients to them. And Newfoundland sometimes sends over, and there's a mixture of patients, and of course the information is having to be photocopied. The liver transplant surgeon in Halifax cornered me the other day complaining about these reams of paper he gets. He probably just needs about 6 sheets of paper. So we have to do a better job for those patients, and there's a lot of them. We're really one almost one province, but don't go there right now. We do share some things very readily. Newfoundland has Screech, New Brunswick has Moosehead, PEI has our Murphy beer, and Nova Scotia has Keith's. I wasn't able to fit their picture on there, but we could do a lot better with our sharing and our data sharing as well. That's an old story we all know, but it's particularly relevant in the Atlantic region with the patient sharing that we have. I think looking ahead, our Atlantic communities, and I'm just focusing there because I think I'm the representative for today, need to communicate better. I sat at the table with some ladies from New Brunswick and I learned a little more about what's going on with their EMR. I'd been involved a little bit earlier, but I learned a lot today just by talking to them. I've had experience with CPOE, but not with primary care, and we're going to need some help with that. And there's lots of experience out there with Nova Scotia and New Brunswick. When I say triaging implementation, Dr. Harris actually did it, didn't he? He talked about today about Big Bang versus how he did it. We did the same thing. We actually went to implementing viewable documents, the nurse documentation, and then physicians had to go on to get the lab, and then we moved along to CPOE. And the other triaging part to me is primary care versus the hospital base. I think the hospital base is where the bigger risk is. The primary care base is where politically you may get more bang for your buck. With the patient portals and things, and also the numbers are there for the numbers of encounters. Cost sharing is something that certainly in Atlantic Canada would be nice to see when we're getting together on, or when people are choosing projects and vendors. There's a potential there to get together and have some cost sharing, and that's not been happening either. What I hope to see is what Dr. Harris is talking about, what everybody's talking about, a national, reportable set of data that will help us make quality decisions in the future. Access to the patient's chart concerns me, broadening it. I'm naturally conservative, but there's certainly lots of good reasons to move to some degree in that direction. The most exciting project, that was me Christmas Day in the operating room, is the surgical synoptic reporting that I'm involved in. It's something new for us. We've just started reporting on breast cancer patients, and I got to go to the latest Canadian Partnership Against Cancer and meet with the surgeons. I was the only non-surgeon in the room. Very uncomfortable place for an anesthetist. But I was very impressed with these gentlemen and ladies, their commitment to getting quality data to report on outcomes of cancer surgery, because most cancers are cured by surgery. And we actually don't even know the best treatment for ovarian cancer in Canada. You can pick your surgeon and get whatever surgery it is you want. And we can do better. And there's some movement toward great information in that reporting piece. And I'm happy that we're starting on that. Was that it? So how do we get there? To me, Infoway is the only way Prince Edward Island could have gotten anywhere off the grid with the co-funding, and I think supporting them as they move ahead with their strategic plan is key. I'd like to see a network of CMIOs set up. I'm very alone right now, and the wolves are circling every day, so I'm glad to meet these guys. And I think provincially, the regions that are tied together should work on having some sort of an information exchange so we don't make the same mistakes and we can grow together. Thank you.
So thank you. It's a pleasure to sit here with these gentlemen and to be able to learn from them. Big issues. I think we all face similar, very large issues. I know that Glen is going to speak to some of those, but when we think of our aging demographic and when we think of our increasing healthcare complexity and cost, we are facing those every day. And so what haunts me in my dreams at night is capacity. And capacity not only in the informatics area, but that's of course what's haunting me most recently. But we looked around the room the other day at a leadership meeting and we asked ourselves, where are the leaders of the future? And they were not in the room because everybody was my age or older. So Bill and I are getting tired in the province of BC and looking for other folks to kind of come up and lead the charge. And so capacity worries me. Leadership, clinical capacity worries me. We've got an aging demographic of clinicians too, and changing demographic of clinicians with different lifestyles and different goals and values. And analytics capacity really worries me. big issues there, I think, and informatics capacity as well. So those are some of the things that I think are big issues that relate to some of the other big issues that we're trying to solve. And we need visionaries and leaders to help us solve those. And it's gonna take time, and it's hard. Otherwise, we would have made greater progress. In terms of, what was the next question?
Vision for the role that IT and digital health can play to address.
That's right. Yeah, thank you. So IT, so interesting. Bill in his slide mentioned I am IT. And so IT as an enabler, I think we say that a lot, and we need to make it so and not a driver. And I think we need to focus more on the I am part. And so that's another area that I like to think about a lot and try to encourage in our healthcare system, a greater focus on information management as one of our greatest assets. Certainly, I think what I'd like to see, along with a much more around personal health records and patient empowerment in that regard, and I'd love to document with my patients. I can hardly wait for that day. I'd love to be exploding the use of e-visits in whatever shape or form. I'd love to be able to do that in a safe and appropriately private way, and not have to worry about it and be able to do it wherever I am. Certainly what I think we will need is super smart systems. So along with getting old, kind of feel that sometimes losing the edge a bit, and so looking for systems to be very intelligent, looking for pattern recognition, looking for trajectories, looking for intelligence, looking for predictability, and beyond what we can even imagine. What am I working on right now that is keeping me tired and old? One patient, one record, one plan for health and care is our slogan on Island Health, not dissimilar to many of your initiatives that you're all working on, but a little bit different in that we're consolidating all of our information systems on a Cerner platform. So we're replacing our systems in residential care with Cerner, and we're replacing the systems that our home and community care individuals use with Cerner, and really wanting to exploit mobility with Cerner, and replacing in our ambulatory and primary care owned and operated centers the systems that they're currently using with Cerner. And so that's quite different and quite big, and is, I think, also really exciting for us, and really looking forward to it. We've got a great team of very motivated and excited clinicians, and so talk to me after March and see whether I'm still excited, and if we've still got motivated clinicians, or if I'm being run off the island and looking for a job by my 2,000 physician colleagues that I somehow have to convince to do this with me. Should we be working together? Absolutely, yes. How? Boy, it's been hard, I find, to have the time. I would like to see our CCIOs and CNIOs meeting with our CMIOs across Canada in a very different way, focused on some of the really hard stuff we're trying to solve. I pick up the phone to my colleagues here, and I do have a group of CMIOs here in BC, so I'm very fortunate, and ask them really tough questions sometimes. And we need to expand that to include our CCIOs and our CNIOs, because there's issues that we have not solved that we need to solve. See one, do one, teach one. It's an old medical school saying, and I think we need to do that. And we've picked up the phone because we're poor souls on the island and feel a little bit stranded, and so we call our colleagues in Ontario and say, hey, we need a pharmacist. We've had Jeremy and Sonia come out a couple of times. We need help, and we need to learn how to do that. Publicly funded systems should be working more collaboratively together, and we need to figure that out. I think we're inviting people out to our go lives so that they will have some experience with a go live, so that when they go live, they'll have done it already. So it is that see one, do one, teach one. We had some folks from Ontario out testing with us last week. So we can test the system that we've designed. We can have our end users test it, But what about having someone who's already gone through it on Cerner come and kick the tires a little bit even more? So those are some of the things that we're doing, and I think we can do more in that regard. And certainly looking forward to, Eric's not here today, Dr. Grafstein, but looking forward to collaborating with the CST project here in Vancouver and trying to figure out how we can share resources and learn together.
So we were sort of asked to address what we think or what concerns us the most, and I decided to use as the metaphor my thinking about the perfect storm itself. I don't know if any of you remember what the perfect storm was. As I think most of you know, hurricanes are tracked by the International Weather Service. They all have names, but not that one. That hurricane is actually called Unnamed Hurricane 1991. And it was referred to as the perfect storm because the hurricane formed spontaneously out of 3 colliding weather systems. It didn't exist before, and that's why it never got named. It suddenly formed over the Atlantic, and there's a story about this and so on. So I decided to say, well, let's talk about the 3 colliding pressures that the healthcare system is facing, and certainly what I see as an important role for healthcare IT to sort of try to address these issues. So none of these are unfamiliar to you. The rising cost, I believe Canada is reaching or about to reach 11% of GDP is being expended on healthcare. That figure continues to rise despite our best efforts. Recently, the rate of rise has leveled off, and that may hold for a while. I suspect that without clinical IT, it may be very difficult to keep that from rising again. Increased focus on care quality and patient experience. We hear this from American colleagues as well as in various jurisdictions in Canada. Pressure to deliver better care with no more money is continuing to increase. Patients expect better care coordination. We heard this morning from the patient advocate, Cecil, that this was his perception that quality care had not been delivered. Right? This pressure is going to increase, I suspect. And we have pay-for-performance initiatives, we have QBPs in Ontario, we have other manifestations that the pressure on our care delivery is increasing, and the scrutiny of our care delivery is increasing. I don't believe these are problems we can solve, or I advocate to this group that I don't think we can solve these problems without healthcare IT. And then the age of the population, everybody knows this. I don't need to refer to this in this group. The same thing, these pressures are colliding and are creating the situation which some of us would consider to be a perfect storm in healthcare in the next few decades. So I sort of want to suggest a two-pronged approach to how we look at healthcare IT investment. I don't think, I'm not going to talk about the minutiae, about getting down to individual systems, individual technologies, but rather 2 broad-based approaches. And you heard about some of these this morning. Once again, this is nothing new. Process management, care process management, I think Dr. Harris called this care pathways. But whatever it is, we need to improve productivity and care quality by standardizing and automating best practices. You can say that in other words if you want to, but I think most of us recognize if you want to deliver or address those 3 issues identified in the previous slide, you're going to have to do some version of this. You can call it something else if you want, but it's going to involve this to some degree. And healthcare analytics. Most of the people in this room are well aware of the potential that healthcare analytics, sometimes called big data, could be used. But I think compared to the rest of the world, other industries, if you actually look at it, healthcare is ridiculously behind in the use of healthcare analytics. Identifying patients at risk and identifying specific interventions for those patients in a comprehensive way and proactively managing those healthcare issues for that individual patient, not the system. We've got a lot of data extraction at a system level, but real-time intervention for individual patients is something that would be new to us, right? So when I walk by Starbucks here in Canada, my cell phone tells me I'm near Starbucks. They know I'm near Starbucks. I know I'm near Starbucks, and they know what I've been spending. That's how they see analytics. That's how sophisticated their analytics is getting. in healthcare, we have nothing comparable. I'm not comparing patients to coffees at Starbucks. I'm saying other industries have made enormous use of real-time information to address specific individual customers. We don't have any of that, right? That's going to become very important if we want to deliver on those 3 issues I identified before. How do we make progress? How do we work together, right? Was one of the issues we were supposed to talk about. Show leadership to move beyond institutional solutions and implement our vision of comprehensive regional, provincial, national solutions. And you've heard references to that in the panel this morning, as well as other discussions that have been going on today. So we need to see beyond individualization. So for my organization, we need to be looking at how to address concerns in the region. We're already working on a number of regional projects. This is the kind of thing we have to do, and I'm sure you have to do in some of your jurisdictions as well. And I gave some examples of here, and you heard about some of these already today. Functional rich patient portals. It's not enough to give patient information. As you heard from Dr. Harris, patient self-scheduling. I can self-schedule my car into Toyota, but you can't self-schedule into a healthcare appointment today. We're probably going to have to change this. I don't think patients are going to be satisfied. Longitudinal medication management. You heard about that this morning in the panel, right? Talking about how we manage medications across a region, across a jurisdiction, from primary care to acute care and so on. Regional diagnostic CPE. What do I mean by that? Primary care physicians being able to enter orders in their EMR and having them figure out where in the region this patient is going to get their CT scan the most quickly. That would require a lot of cooperation and a lot of stakeholders to do that. Large-scale clinical interoperability, right? We've talked about that a lot at this conference. In order to make this sort of stuff work well for both the providers as well as for patients, we're going to have to deliver interoperability solutions. And that's certainly a new frontier for all of us. Regional healthcare resource management. Think of the politics of this. Well, you know where the new CT scanner is supposed to go? It probably shouldn't go in the Ottawa hospital. It should probably go in the outskirts of Ottawa, right? Horrors, we can't have that, right? Like this is the sort of stuff where the kind of things we're going to need to do to deliver services to the population is going to have us need to think about these things using analytics and analysis to tell us how to address these types of concerns. So these are examples. The list is not intended to be complete, but rather suggestive of the kind of things we could do. Thank you.
So I'm going to speak mostly from the acute care side because I work in a hospital and I am a gastroenterologist, although as a disclaimer, I was not involved in any colonoscopies of any of our speakers from this morning. But since I don't have slides, I'm going to try to just appeal to your imagination about a couple of ideas. First, in terms of challenges, I really only want to talk about 2 things. The first, I think, is that in Canada, we have a huge challenge just with the sheer cost in terms of the financial resources and the people resources necessary to get us where we need to be with advanced clinical systems. And when you look at the United States, which now 74% plus of hospitals are at HIMSS stage 4 or above, and we know that stage 4 is really where the systems really start to actually change patient outcomes. In Canada, does anyone know in the room where we're at, stage 4 and above? It's 5.9% of our hospitals are at stage 4 or above. So we have a huge challenge there because we don't really have any provincial or federal funding programs like in the United States to get these systems up. So that's number 1 challenge. But I think number 2 challenge, which is even bigger and perhaps more dangerous, is how are we spending that money and how are we leveraging that investment? Because if we implement systems and all we're doing is checking off checkboxes on the HIMSS MRAM, then we're actually not going to get the patient outcomes that we all desire, right? Because we know from studies in the literature that you can implement the same vendor system in one hospital or another, and it's all the details of how you dovetail the workflows, how you change the culture in an organization, and how you build in decision support and standardization that make the difference between those 2 systems. One might have negative patient outcomes, and one's going to have positive patient outcomes. So I think we need to change the conversation, not so much amongst the people in this room because we're preaching to the converted here, but North York General, because we were one of the first HIMSS stage 6 hospitals, we've had visits from many different hospitals across the country, and the conversation that's happening at the leadership table in many hospitals to date is still, well, we just need to get to HIMSS X. And if all you're doing is checking off boxes on a technical functionality scale and you're not really thinking about meaningful use, then all that money we're going to spend, which we don't even have, is not going to get us the results we want. So we need to really be starting to look at how do we, as a country and as the provinces, how do we incentivize meaningful use and meaningful implementations that actually drive patient outcomes, because that's what we're all here for. So if we look at the potential solutions and sort of where my vision is, I'm going to make you think of, if you can imagine, a pyramid and a cube. So if we think about doing more with less, because that's what we all have to do, whether it's health IT or just healthcare in general. On the more side, if we can think of a pyramid. So at the base of that pyramid is meaningful mindful implementations. So it's not just plunking in a vendor product, it's making sure that we engage our clinicians, all of our healthcare providers in redesigning workflows, changing culture, building in evidence and best practices so that we're leveraging the most important benefits of advanced clinical systems. The next level up, once you have that foundation, is actually using structured data based on recommended standards. And Infoway has done a lot of work around what those standards should be and how they should be used. But still to date, we have very little, it's almost non-pervasive, that actual use of proper standards. And we have almost no data interchange, and where we do, most of it is just non-discrete data. It's just chunks, which doesn't mean anything to a system if we're going to actually help clinicians make better decisions with patients. So it's building that layer of structured data that then at the top of the pyramid allows you to do decision support and analytics, where the system now knows, oh, this patient doesn't just have a bunch of documents, it has these coded diagnoses and these coded medications, and it's shared across venues, so that now we can make intelligent decisions about, well, what is the best thing to help this particular patient? And then how can we look at a level, not just the patient, but also at the provider level and the organization level and the community level and the health system level on those analytics. So that's the pyramid on how we can do more with the investments that we have. And then how do we get those investments for less is the other piece. And so if you think of a cube, I think of this sort of in 3 axes. On the x-axis, we need to do more horizontal integration, and I think Mary-Lyn talked about a little bit about this. The idea that we're a publicly funded healthcare system. We are not in a competition. We're just trying to accommodate the population that we have. So we need to be working together more to leverage all of the investments that we've all made. We've all become experts in different things, and we should all be sharing that knowledge and trying to cluster, not just in vendors and in sharing server farms and so forth, but clustering our knowledge, because there's actually a huge shortage in Canada of real high-quality healthcare IT knowledge. So sharing that, I think, is really important on the x-axis and doing that horizontal integration. On the y-axis, the vertical integration, we need to change how we deliver care. And I think we heard a little bit about this morning from the Cleveland Clinic, that this idea of an accountable care organization, the vertical integration where you don't have, primary care is one silo, and hospital care is another silo, and rehab is another silo. It all needs to be one piece, so that essentially we're providing comprehensive care to patients and sharing all that data across a continuum. And that means changing the way that we're accountable and how we're paid for these types of care episodes. And then finally, on the z-axis, I think we need to think about how we connect everyone in the system. So it's not just about providers, it's about the providers, but the patients, their caregivers, their families, patient navigators all need to be connected to this data so that we can do all of this proactive health maintenance and prevention and course corrections along care, where patients and families are actually going to find stuff that we overlook if they're sharing the data. So in terms of what we're doing at North York and how we see this sort of integration piece, some exciting projects we're trying to do. One on the horizontal integration axis is the Infoway funded CPOE toolkit, where we've created a repository of order sets that's available nationally to any hospital that wants to start implementing CPOE, as well as best practices. And then in the vertical integration, we're doing something interesting now at North York around a clinical data repository, where we're taking actually community-based primary care data and our hospital-based data, we're matching it on discrete data level and actually starting to look at how that shared data can improve patient outcomes and improve value for healthcare dollars. So thanks. Oh, and there was a question. Oh, yeah, so you probably want to know what my idea is for the next panel. All right, so I have a toddler at home, And I've discovered that toddlers are fascinated and they giggle to no end whenever there's violence. So I've understood that, my daughter, she likes to pretend to kick me in the face and she laughs uncontrollably. But I've discovered it's actually part of human nature. So, we're all being very collegial up here and we're all kind of agreeing on the same things. That's not very exciting. So I've talked with Jennifer, and in our next, perhaps the next partnership conference, we're actually going to have a steel cage match amongst the CMIOs. There's going to be a real physical confrontation, and it'll be on pay-per-view. So I hope you like that idea for the next one.
You can wear those sumo wrestling costumes.
Yes. There we go.